Okay. The next speaker up is, again, an old friend of the Centre and a visiting professor with the Centre for Biomedical Ethics, but he is actually not physically with us today, so he couldn't come for this conference, though he'll be here later in the year. So Professor Dominic Wilkinson is Professor of Medical Ethics at Oxford and Director of the Medical Ethics and Deputy Director of the Uehiro Centre of Practical Ethics. So he's a consultant in newborn intensive care at the John Radcliffe Hospital in Oxford, and he's also a senior research fellow at Jesus College, Oxford. So I think you probably will know he's a very well-known ethicist and medical practitioner. So this is really right squarely in his area of expertise. So we've got a pre-recorded talk by him, and he'll be speaking on ethical issues in neonatal end of life. And I know we did a case on neonatal end of life a short while ago, so this hopefully will kind of, the icing on the cake as such. So again, it's very weird. We're introducing somebody. I wonder whether you should clap or not. I don't know. Anyway, here's Dominic on his talk. Thank you.
Hi. It's great to join you for the meeting. I'm sorry I can't be there in person. So what I wanted to do in this lecture is to apply the concept of best interests to the types of decisions that I have to make regularly in neonatal intensive care. And as will become clear, this is difficult best interest decision making for a couple of reasons. One is because it relates to somebody whose own views are unknown and unknowable. Second, it relates to some very fundamental and difficult questions about life and death. How do we approach best interest decision making for somebody when we're contemplating whether to keep them alive or not? I don't have any conflicts of interest in this talk. For those who are interested, some of the issues in this talk are ones that I've covered in some of my previous books. As this slide indicates, ethical questions to do with the care of newborn infants or children at the end of life, we can divide them into three different categories. And in this short lecture, we'll certainly cover the first two of these, and we'll see how we go with the third. So one type of question is when or why it might be appropriate to make decisions that might allow a newborn infant to die. The second type of questions are, well, how do we make those decisions, or perhaps more pertinently, who makes those decisions, and what happens if the different parties disagree? And then the last type of question is, well, what decisions are we allowed to make? What would plausibly count as being in an infant's best interest? So I'm going to start by talking about a case that I was involved with a number of years ago. A mildly premature baby diagnosed before birth with a significant brain abnormality, with swelling of the fluid spaces in the center of the brain. Significant concern before the baby was born that this baby's brain functioning might be very abnormal. And indeed, when the baby was first born, was unable to breathe, ended up on a ventilator, and indeed had marked abnormal functioning of the brain, which didn't seem to be something that neurosurgery could relieve. This wasn't a situation where relieving pressure was believed to make a difference. But this infant was stable on the ventilator. So to focus on this question of when or if it would be ethical to withdraw treatment and allow the baby to die, one thing that I'm going to encourage you to do is to have a think about your view on this sort of case. So in a situation like this of a newborn infant with very worrying looking outlook, would it be in the child's best interests to die? And you might have the view that no, it would be in their best interest to live. It would be wrong to withdraw treatment. You might think that well, it would be acceptable if parents agree to withdrawal of treatment, but also ethical to continue intensive care. Or you might think that it would be ethical to allow the baby to die. Indeed, it would be wrong to do the opposite, to continue the ventilator and to keep the baby alive. So I want you to have a think about that, and perhaps you could write down your answer or ask a friend. But whichever of these you side with, and I'm going to suggest that most people in this audience will probably think either the middle or the bottom of these options, we might ask the prior question, well, why would it be acceptable in this situation not to do what we technically can do, which is to prolong life? Well, if you go looking in medical records, and our medical records don't tend to look like this anymore, they all tend to be digitized, at what doctors have written when they've said why they're stopping the ventilator or allowing a baby to die or making decisions with parents to limit treatment. These are the sort of words that we often talk about. We say that treatment would be futile, or refer to the child's poor prognosis. But with either of these, we might say, but what do we mean by futile? What counts as futile? In fact, I often, or indeed what counts as poor prognosis? In fact, when I teach people about medical ethics, I often refer to the word futile as the F word in medical ethics. And that's because it's become a bad word to use. And I'll point out some of the problems with the term in a second. But because people recognize that it's not perhaps any longer a fashionable word to use, they'll sometimes use one of these other terms instead. So they might refer to treatment as not clinically appropriate or non-beneficial or not medically indicated or inappropriate or inadvisable, etc. But in any of those cases, we might still ask, but why is it not appropriate? Why is it not indicated? What makes it inadvisable? The problem with all of these terms is that they're vague. Often in themselves, it's not clear exactly what it is that we're referring to. If we're referring to the chance of survival or the chance of improvement, it's often very difficult to define where that threshold is, or if we're referring instead to a level of functioning that would make treatment futile, it's very difficult to define what level of function would make treatment futile. And then even if we could define it, even if we said, look, there's a less than 0.1% chance would make treatment futile, how do we determine whether there's a 0.1% chance for an individual patient, given the often unique features, or in every case, the unique features of an individual case? So there are problems with the concept of futility, and I think there are better answers that we can give. So why would we not provide treatment? Well, if we move away from the newborn infant case to the more general situation about providing life-sustaining treatment or prolonging life, of course, in medicine, we have a strong ethical imperative to prolong life if we can. But there are three basic ethical reasons why we may choose not to prolong life even when we could. One of those, with which you're all going to be very familiar, is on the basis of autonomy. That tends to come right at the top in terms of ethical principles. So that's on the basis that the patient wouldn't or doesn't want it. And indeed, many of us are familiar with the idea in adult medicine that even if it's clear that treatment would be beneficial, if the patient has capacity, they're able to make decisions, and they refuse it, it would be wrong to provide that treatment and may be unlawful. But of course, autonomy is not relevant in that way to young children or infants, because they're never able to voice that reason for not wishing for treatment. The bottom principle, the principle of distributive justice, is one that we're aware of, but in high resource settings, like Singapore or like the UK, most of the time we can avoid this particular reason, though it's incredibly relevant to most parts of the world where resources are limited. And indeed, even in Singapore and certainly in the UK, there are finite medical resources, and we do have to think carefully about that. And of course, the relevance of limited resources is that just because we can do something doesn't mean that it would be the right thing to do in a situation where somebody else might have a stronger claim to that resource. It would be wrong, for example, to provide a scarce heart transplant to a patient who has a very small chance of benefiting from it if somebody else has a much higher chance of recovery and long survival. So those are principles of distributive justice, which might give us a reason not to try to prolong life. But again, we're able to skirt or avoid that question most of the time because we have enough resources for most of the patients, at least, that we care for. So instead, what we're focusing on for this patient I've described and for many of the patients who I look after, on questions of best interest. Would it be in the patient's best interest? And best interest, although it's a very important ethical principle, it's one that you're thinking about a lot over the course of this meeting. In itself, it's opaque. It doesn't tell us how to determine whether or when treatment would be best for a patient. Broadly speaking, and I'll come back to this, when I think about best interests, what I'm engaging in is a weighing up of pros and cons, or more specifically, benefits and burdens of treatment that I might be contemplating for an infant. Do the pros outweigh the cons, or in some situations, the opposite? More specifically, and drawing on a way of thinking about these decisions that we incorporated a number of years ago into a framework for decisions in the UK, we can think about best interest decisions in two categories. One, situations where the quantity of life that we can provide with our treatment is small. The other, where the quality of that life is reduced. And within each of these categories, we can subdivide them. So within quantity of life, the most extreme situation is one where the patient has, in fact, already died. Now, this might seem like an odd thing to be talking about, whether we should prolong life in a situation where there is no life. But actually, it's become clear over recent decades that it's technically possible to support somatic life, to support the circulation, continue ventilation for patients who are brain dead. But of course, in very fundamental ways, what matters has ended, and legally they're regarded as already having deceased. So that's the most dramatic situation where we can't actually prolong legal life with our therapies at all. Perhaps the most obvious, and in some ways the simplest situation where we might choose not to continue our therapies are the patient who's imminently dying despite maximal therapy, the child or adult with refractory shock or hypoxic respiratory failure despite maximum therapy. In that situation, it simply isn't going to make any great difference whether we continue therapy or not. And indeed, we may choose to withhold further interventions, for example, CPR at the end of life, because that will simply make no difference. Or we may choose, in the in the final stage is to focus on the patient's comfort in the hope that they and their family are able to improve the quality of the last part of their life. So this is a situation where the quantity of life that we can offer with treatment is small. And a third category is where patients can survive, but not for very long. Patients who might survive for perhaps weeks or months. For example, patients with metastatic malignancy despite treatment, or in my area, children with very severe genetic or metabolic conditions that are untreatable and who have a life-limiting illness. In those situations, although we might be able to get a child through their acute illness, the question is whether it would be the right thing to do given the short amount of survival. And in some cases, it would be, in others, it wouldn't. But one potential reason it wouldn't would be because of the quality of that existence. So here we move on to the other type of reason, best interest-based reason for not prolonging life based on the quality of life that somebody would experience. Now, in that setting, we come up against a profound question, a question that a number of people struggle with, which is whether it could ever be in somebody's best interests to die. And for some, the answer to that question is no, but we might phrase it a different way. In some situations, it might not be in somebody's best interest to prolong their life. And that might be in particular because of the unpleasantness of what is involved in keeping them alive. So if we think about quality of life reasons, using the concept of best interests, the clearest situation when it would be in a child's best interest, or indeed an adult's, not to prolong their life, is where the burden of the treatment that's required to keep them alive is so great that it outweighs the benefit of being alive. And that applies particularly to some very invasive and unpleasant life-prolonging treatments that we use in intensive care, mechanical ventilation, extracorporeal membrane oxygenation, dialysis, but of course also some very burdensome treatments outside intensive care, extremely unpleasant chemotherapy, major, really radical surgery. In those situations, it can well seem that the burden of those treatments would outweigh the benefits of longer life. In other situations, it's not necessarily the treatment itself that is burdensome and unpleasant, causing pain and suffering for the patient, but rather their underlying illness. For example, again, patients with advanced malignancies and severe and intractable symptoms, or children with severe congenital genetic syndromes affecting their skin or bones, causing intractable seizures. Of course, we can and should do everything that we can to relieve those symptoms, but despite the very best symptom management, sometimes for the remainder of an individual's life, they will continue to experience such severe symptoms that it may not seem the best thing to do to prolong that life. So those are two situations where quality of life might seem significantly reduced or negatively affected to the degree that it may not be the right thing to do to prolong life. But there's another situation that doesn't necessarily involve active suffering, but where the benefits of life, what's on the left side of the seesaw, seem to be reduced. That can be, as we mentioned already, where life, the length of life would be reduced, but also in situations where the individual's experience and their positive experiences, their pleasurable experiences, are reduced. So in this third category of lack of benefit, that most clearly and obviously applies to situations where a child, or again, an adult, has profoundly reduced awareness of their surroundings and consciousness. Most evidently where, for example, it's believed that they have no conscious awareness of their surrounding, they're in a vegetative state, or in the overlapping but slightly less dramatic, minimally conscious state where they have some minimal, sometimes intermittent conscious awareness of their surroundings. In that situation, the benefits, the positives of continuing life may seem significantly reduced and potentially outweighed by the negatives. And of course, as already alluded in my discussion of these different cases, there may be combinations of both reduced quantity and reduced quality of life. So if we think about the case that I started with, the child who's ventilator dependent with profound and untreatable brain problems, it is, I think, inevitable that that child will die early in life as a consequence of their severe congenital problems. It also seems that the treatment that is involved to keep them alive is significantly burdensome. Depending on the nature of their symptoms, we may or may not think that life itself is particularly burdensome. Some of these children have very distressing spasticity or recurrent seizures. Others appear to have very little experience of anything, very much. But profoundly, it seems that this child also has a lack of benefit of continued life prolonging treatment. So these three factors may combine. Why does it matter to divide up these situations, to divide up these different reasons? Well, recognizing that there are different types of end-of-life decision, different types of reason why we might not prolong life, has different implications. There are different implications for which treatments we provide. If we think it's a situation where life has no benefit, we may decide to withdraw all life-prolonging measures, even those that would be relatively simple. If it's a function of the burdens of treatment, it might be that we provide some non-burdensome life-prolonging treatments, antibiotics, blood transfusions, oxygen, but withhold other burdensome ones like cardiopulmonary resuscitation, dialysis, or ventilation. And recognizing that these different types of decisions have different implications means that for some of them at least, they fit more comfortably with people's concerns about questions of the value of life. So the reason to stop treatment varies between situations. There's a spectrum, and across these different categories, what you might have recognized is that as we move from A to C in both quantity and quality of life, we move into situations that are more controversial, less clear-cut. And for both of those reasons, we might think that there's increasing relevance of the parents' views to help us think about when it would be appropriate to limit treatment. And I'll come to that in just a second. At the other end of this spectrum, where we're talking about brain death or extremely burdensome treatment, it's much less controversial, much more clear-cut. And we may well think, again, as I'll come back to, that it's less, there's less of an option to perhaps continue treatment, even if parents wish for that. So just to summarize some take-home messages from this part of the talk, it can be in a child's best interests to die, or to frame it in another way, for those who still struggle with that, there are many situations where it may not be in an individual's best interests to prolong their life. It may be in their best interests to have a shorter, more comfortable, rather than a longer, more uncomfortable life. And although I've talked about children, these same questions will apply to adults, though the relevant difference when we're thinking about best interest decisions for adults is, of course, that we can incorporate, and we should incorporate, their views in thinking about how to weigh up these benefits and burdens. Secondly, I've argued that when we're thinking about making these decisions, we ought to be clear about the reasons, that we ought to try and avoid these vague terms like futility or poor prognosis or medical inappropriateness, that we can do better than that, and that we can think about the ethical reasons why it's not in the patient's best interest to prolong their life. And thirdly, because the reasons are different, that has different implications. So not all cases where we make end-of-life decisions are the same, and that yields different conclusions about those end-of-life decisions. So I'm going to move now onto the sort of second group of questions that we might ask about end-of-life decisions, which is about who makes decisions about treatment. So this is another child who I looked after a number of years ago, extremely premature, but also very growth restricted, who'd been in intensive care for a very long period of time, indeed, had remained in hospital in intensive care for months. And when I first met them, they were now 8 months old, still ventilated, still extremely unwell, and indeed in the last month had been on maximal respiratory support. So we can ask the same sort of questions about this case. Would it be ethical to limit treatment? I'm going to skip over that, partly because I think I suspect all in this audience would be comfortable that in this situation it would be appropriate, but because I want to move on to this other question about, well, who should make that decision about limiting life-sustaining treatment. So here's another question for you to think about, and again to perhaps note down or chat to a neighbour. And here are some different possibilities again. So you might think that, well, it should be the health professionals who should decide in this and other cases. Or you might think that this is a decision for parents to make. Or you might think there's something in between. So you might think health professionals should decide, but parents have to agree with that decision. It should be health professionals and parents together who should make the decision, or that it should be parents' decision, but with the support and help of health professionals. One interesting question to help us think through this is what parents actually want. And the evidence from parents who've had to make end-of-life decisions for their children, their testimony indicates that most wish to be actively involved, indeed wish to be the ultimate decision maker, though not all. And there's some suggestion in this research that those parents who are not actively involved in decisions might have more negative psychological consequences from decisions. So there's challenges in interpreting some of this evidence. So I've alluded already in the question, what we're talking about here is a term that's familiar, which is shared decision making. And when we're thinking about best interest decisions, we very often are trying to engage in sharing those decisions. If we're talking about best interest decisions, we're talking about sharing the decision between the healthcare team and the parents or surrogates. For patients who are conscious, we're often talking about sharing the decision with the patient to a variable degree. And as my poll question alluded, there's a spectrum of shared decision-making, from the patient or the surrogate making 100% of the decision to the healthcare team, the doctor and healthcare professionals making 100% of the decision. And when we're making best interest decisions for children, one question is, I suspect most of you chose one of these options in the middle, one of these options that involve shared decision making. But where should we be on this spectrum? Should we be more at the parent end or more at the health professional end? Well, one answer is that it depends on what parents wish for. It depends on parents' views. So as the empirical evidence that I summarized indicates, many parents wish to ultimately make decisions, but with support, but not all. So some parents may wish for the healthcare team to make most or indeed all of the decision because it's too burdensome for them to make that decision. And of course, the cultural and ethnic background of the family will influence their views about how much they wish to be involved in these decisions. So one important question for us as practitioners is to try and find out from parents how much they would wish to be involved in these decisions. But whether it's for children or indeed for adults, as this study indicates, actually the most common or the most significant determinant of where decisions are on the shared decision-making spectrum is not the family or parents' preferences, but the doctor's preferences. So in this study from the US a few years ago, when they taped conversations between families and health professionals about patients who are critically ill, they could identify those conversations as being across this spectrum from informative, telling the family what was going to happen, and then allowing them to decide, to directive, telling the family what was going to happen, and everything in between. But it seemed that where the conversation was on the spectrum largely depended on the preferred style of the health professional. Some health professionals prefer to make decisions, others prefer to let the families make decisions. So this is pointing out that in practice it doesn't look like we always remember to ask families how they wish these conversations to go. But there's another factor that's relevant to thinking about where we should be on the shared decision-making spectrum, which is the nature of the situation itself. So one way that another diagram that I often use in thinking about best interest decisions is this one. So if we're thinking about the scales, again, weighing up the benefits and burdens, very simplistically, if the benefits outweigh the burdens, where we have net benefits, it would be in a patient's best interests and we should provide the treatment. And if the scales are tipped against treatment, it's not in a patient's best interests, we shouldn't provide the treatment. So all we need to do is to work out whether we're above or below this line. But this simplistic model doesn't really fit with how we make decisions. Apart from anything else, it seems to leave no role for parents in thinking about how we make these decisions. And of course, we do very regularly involve parents or involve families in thinking about how to decide if treatment would be in a child's best interests or not. In practice, we have a model that looks much more like this. There are situations where it's unquestionably in a child's best interests to prolong treatment, to provide them with life-sustaining treatment. A child who has an acute, reversible, critical illness, it's absolutely clear that we should provide that therapy. It would be in the child's best interests, and indeed, we wouldn't have a serious conversation with parents about whether we shouldn't. At the other end of the spectrum, there are situations where it's not in a child's best interest. and we ought not to provide that treatment. Again, potentially regardless of what parents' wishes are. And then in between, we may be in a situation that's sometimes in neonatology called the grey zone. More broadly in pediatrics, we could refer to this as the zone of parental discretion, where there can be significant uncertainty. It may be reasonable either to provide life-prolonging treatment or to withhold that treatment and to allow the child to die. And when we're right in the middle of this zone, we should, in talking to families, in reaching these decisions, be very much influenced by parents' wishes. However, sometimes, as already alluded, we're not in the middle of this zone. We are at best in the lower part of this zone, or perhaps we think that we've already crossed over into a situation where treatment would not be in a child's best interest. In that situation, when we approach families, we should not be saying to them, what do you want to do, but rather to be directive and indicating what we think needs to happen for the child. Very sadly, that we can no longer help them with our treatment, like the case that I mentioned of this child with very severe respiratory failure. We should be indicating to them that what we need to do, sadly, is to stop doing things that aren't working, to focus on the child's comfort and allow them to die. But as occurred in the case that I mentioned, parents may not agree. And so we may have to think about when parents' views should be overridden. If we're thinking about this framework, this diagram, there are boundaries to this central grey, or in this figure, hashed pink zone. And those boundaries are set by what is sometimes referred to as a harm threshold. When parents' decisions or preferences for treatment to be provided or continued would cause significant harm to the child, or where parents' refusal or declining a treatment would be significantly harmful to a child. We cross out of this zone of parental discretion, we cross a harm threshold, and we're in a situation where health professionals ought to potentially look for ways to provide that treatment or not provide that treatment contrary to parents' wishes. So this raises a practical question in relation to best interest decisions, which is what to do if parents and doctors don't agree about a child's best interests. And this is something that I, together with Julian Savulescu, wrote about in relation to a controversial and high-profile case in the UK a few years ago. So here are some practical advice about how we should think about those decisions, and they apply to pediatrics, but they also apply to the adult cases that I'm involved with in my role in clinical ethics. What we need to do is to identify early, if we can, when we and surrogates or parents are disagreeing. And the reason for identifying early is that the evidence is that such disagreements, if allowed to continue, can become more difficult to resolve, more intractable. We could think about a sequential approach to resolving disagreements around best interests. That might involve internal second opinion. It might involve speaking to clinical ethics consultants or a clinical ethics advisory group or committee. It can involve mediation, using those with specific training in addressing significant disagreement. It can and should involve, in some cases, exploring external second opinions, or indeed even transfer of the patient to another hospital in situations where the local team are not willing to provide an option, but somebody else is. And in some cases, certainly in the UK, but potentially also in your part of the world, we may need to ultimately go to the courts to ask for them to help us resolve the disagreement. In all of this, and whenever we have these difficult disagreements, we need to remember to address the suffering of the patient and make sure that while we're going through this process, which typically takes a long time, that we have excellent symptom management, that we need to address the suffering of the family and the parents because these disagreements are extremely distressing, and address the suffering of our staff. I'm going to finish up here, finish up the talk. I've talked about shared decision-making as a way of approaching best interests decisions, and I think there's strong reasons that we should do that, but that shared decision-making is not a single thing, that there's a spectrum of shared decision-making. We should ask parents what support they need or prefer. We might ask them if they would like a recommendation in situations where it's appropriate to provide one, particularly towards the edges of the grey zone. But also recognizing that there are limits to parents or indeed family surrogates' views. They should not be accommodated if they risk serious harm to the child for paediatric decision-making, and potentially for adults making best interest decisions if their views we think would be seriously harmful to the individual and contrary to the wishes, what that person would have wanted. I'm going to stop here. Thank you very much.